Everyone. At this onset, I thank Georgina Sir and the entire ECMT team for this great opportunity. Whenever ANCA vasculitis meet tuberculosis, definitely we will have many diagnostic as well as therapeutic dilemmas. So today we are going to present such a case. So we had an 68-year-old lady who presented to us with complaints of frothing of urine. She had around 7 kg weight loss in last few months. Used to have complaints of occasional cough but not productive. No complaints of any hemoptysis, dyspnea, hematuria, any evening rise of temperature. In taking the history in detail, she had a complete history of tuberculosis, which is detected based on X-ray findings. It was sputum negative, and she took ATT for 6 months and then stopped. But no history of any other significant illnesses like diabetes or hypertension. On examination, she was found to have pallor. She was emaciated with a weight of around 42 kg and her BMI was 17.5. All the systemic examinations were within normal limits. When we investigated her in detail, we could see that she had anemia, a raised CSR, and hypoalbuminemia. And over 1 week, her creatinine was slowly climbing from 1.2 to 1.6 and then reached a value of around 2.4. All other investigations were almost within the normal range. Since she had a history of TB and in 2019, and with a history of weight loss, we just did a sputum FP, which was negative. Urine examination was done, which showed albuminuria and urine. It was in the subnephrotic range where urine PCR was 1.5. There was microscopic hematuria around 18 to 20 per field. The UST showed a normal size kidneys with maintained CMD. And when an X-ray was taken, it showed a cystic lesion in the right middle zone and many multiple reticulonodular shadows in the middle as well as in the lower zone. Went ahead with renal biopsy, and in the biopsy we could get around 16 glomeruli, of which 66 were obsolescent. One glomeruli showed segmental fibrinoid necrosis. There was one segmental glomerulus with segmental sclerosis, and two of them showed actually fibrocellular crescent. IF was actually fully negative for all the C3, IgG, IgA, and IgM. And so we could get an impression of focal necrotizing post-immune glomerulonephritis. By the time we got the report of renal biopsy, actually the serological investigations which we sent were also available. And anti-MPO was detected to be 35.6, which is significantly high. And all other investigations, as she had a raised CSR, we ended with an electrophoresis work, which is negative. Anti-PR3 was also within normal range. We went ahead with CT as she had significant changes in the X-ray, as we had plan of starting immunosuppression. And the right middle lobe was actually showing cystic and varicose pattern bronchiectasis, while the bilateral lower lobes were showing multifocal nodules of varying sizes. Went ahead with further pulmonology evaluation with the bronchoscopy and BAL, and that showed an AFP of around 15 to 20 per field of bacilli. We can see the FP bacilli here. And the DH, the diffuse alveolar hemorrhage suggestive picture was also there, as sequential Ellicott-Lavage test was also positive. We also sent an NTM PCR as the sputum gene expert, and the BAL gene expert was negative, and that came to be negative. The histopathology actually showed interstitial lymphocytic infiltrates with loose collection of epithelioid histiocytes, and that was suggestive forming an ill-defined, ill-formed granuloma. So we came to the diagnosis of an ANCA-associated vasculitis, as the DH was also positive and the CT multinodular focal opacities were more suggestive of a pulmonary involvement too. With a renal involvement, we could have a diagnosis of pulmorenal syndrome with possibly a post-immune glomerulonephritis and anti-MPO positive with pulmonary tuberculosis as we had an DAL FP positive. So we went ahead with initiation of IV pulse steroids, which is given for 3 days, and that was followed by 1 milligram per kg oral steroids. She was around 42 kg at that time, so we started with 40 mg steroids, and it was gradually tapered to 20 mg in the next 2 weeks. She was also simultaneously initiated on 880, and a fixed, as by this time, actually creatinine came down by this end of 1 week. So we actually started on fixed dose combination. As Vilesh has already said, we didn't go for a dose modification because creatinine has already reached somewhere around the normal range. And we initiated at somewhere around 3 taps per day, 3 taps daily. And simultaneously, after 2 weeks, we also initiated her on oral cyclophosphamide, and that was given at a dose of 175 milligram once daily. So when we look at the follow-up graphs of this investigations, we could see that the creatine, which had an uptrending levels, like say from 1.1, it has reached around 2.4 at the end of 1 week. When we started the pulse therapy and started initiation of steroids and cyclophosphamide, initially it had a rapid fall to around 1.7 at the end of week 3, and then it reached around 0.8 at the end of 3 months. And urine PCR also subsequently followed from gradually from 1.2 to around 0.8 at the end of 3 months. Microscopic hematuria also gradually decreased from around 20 RBCs per field to around 2 at the end of 3 months. LFT, which actually was normal at the baseline, at the end of around 1 week of initiation of ATT, she actually had a 5-fold rise in ATT. So subsequently, the ATT was stopped and rechallenged one by one, as we had in the previous discussion. It was rechallenged one by one with pyrazinamide at the end. And finally, after rechallenging each one by one, she almost have normal levels of LFT at the end of 3 months. Always, this pulmonary tuberculosis can actually trigger the ANCA vasculitis as well as vice versa. That is, the mechanism is said to be something like a molecular mimicry, because always the cytokines which are released during the time of tuberculosis infection also causes release of this ANCA antigens, which will simultaneously activate the neutrophils, and this will actually release various oxygen radicals and lead to apoptosis as well as necrosis of the neutrophils and the adjacent vessel wall. And this is one of the primary pathophysiology which is said to possibly to involve ANCA vasculitis in this group of patients. There are various reports saying unleashing the ANCA positive power infection, especially after tuberculosis infection, and even vice versa because of the dysregulated immunity. As we know, in immunosuppression in AAV, whenever there is an organ-threatening or life-threatening illness, always the glucocorticoids along with rituximab or cyclophosphamide may be used. Whenever oral cyclophosphamide is used, as we have done in this case, we should use a dose of around 1.5 to 2 mg per kg per day, as we have done in this patient. And steroids should be gradually tapered to around 50% by the end of 1 to 2 weeks. As we see, this is definitely a dreaded complication. Yes, sir. Last slide. This is a dreaded complication, and so simultaneous treatment is always possible, but what we need is a simultaneous multidisciplinary approach to this. And ATT with immunosuppression should be given cautiously, and as we have mentioned in the last slide by Village sir, it's ethambutol and pyrazinamide which actually need dose modifications, while isoniazid and rifampicin do not need dose adjustment. Always a proper screening of infection before initiation of immunosuppression in all patients, whether it be transplant or be ANCA vasculitis, is always necessary. In this case, I think rituximab is something is, I need the opinion of the expert people, but I think rituximab was too risky, and we were also very frightened to start with rituximab regimen, so we opted for cyclophosphamide regimen. And post 3 months, she is doing fine with NADH creatinine of 0.8 and nil proteinuria and microscopic hematuria. Thank you.